Hello everyone, so we're going to continue with our journey to crack down all these big case scenarios into small lines. So we talk about these now. Let's talk about this case. This case, you see an old gentleman or woman, 78-year-old woman, came in with dizzy, okay, confused, and she was started on Bactrim. There was some dysuria, fever, so you gave her Bactrim, okay, like for UTI. And then they ask you, one of the labs that we did is the A1C is like 6.1, and then they give you home medications. She's on a bunch of medications at home, and they will tell you, okay, what would you do for this patient? Like medication reconciliation question. This is very common for the boards. So this one, you want to limit the hypoglycemic agents that they want you to know. So if the patient is on a glyburide, you want to discontinue glyburide. So patient on a bunch of medication including glyburide, the answer is discontinue glyburide, okay? The sulfonylurea in elderly and CKD patients, try to avoid them because they cause hypoglycemia. Okay, that's the idea of this question. Now this patient, 42, has hyperglycemia, like glucose 140, and they tell you what's the best next step. You check the hemoglobin A1C, okay? That's pretty straightforward. And somebody's hypertension, like glucose 140 and hypertension, okay? And this is check A1C. And the reason they ask this question, because they want to bring the discussion that what would you do, what is the workup for somebody with hypertension? So this is what you do. You do sodium, potassium, calcium, creatine, urinalysis, and urine albumin to creatine ratio. This is kind of the general workup, the renal function test workup. And then you do endocrine test, and then you do cardiac test. So okay, you do renal, endocrine, and cardiac test. So we talked about the renal test, BMP, you just do BMP. Endocrine test, you check fasting glucose or A1C along with lipid panel and TSH. Cardiac test, you can do EKG or echo, optional, not necessarily. Other tests, you can do CBC and uric acid as well, but it's not. The most important thing you can do is, so basically you can do BMP, CBC, lipid panel, TSH, A1C, okay? So other CBC, BMP, lipid panel, TSH, okay? UA, EKG, okay? This is like workup for hypertension. Now, so you see 18-year-old male have gynecomastia, bilateral breast. Okay, that's not usual, right, in a man to have a breast, but this could be genetic issues. Okay, could be, there are a bunch of other genetic issues like Klinefelter syndrome can cause that. Okay, so Klinefelter syndrome. So what's the risk for malignancy? Okay, what risk of malignancy in this patient? This one, it's a breast malignancy, okay? And Klinefelter is the most common cause of most common genetic cause of primary hypogonadism, and usually present with gynecomastia and hypogonadism. So the way you do karyotype of peripheral leukocyte and confirm diagnosis. And Klinefelter have increased risk for breast cancer as well. Alright, now they give you another question. It's high yield for the board as well. And for real life, is the diabetic with the ASCVD risk is like 20%. And the age is important here, okay? So they give you 50, if they give you 58, then you do high intensity statin. If I give you 38, this is low intensity statin, because the cutoff is 40 years old. So the best next step, you do increase statin, increase atorvastatin. If it was 20 milligram, you just increase it to 40 milligram or 80 milligram. Other patients that you want to increase the statin for, if LDL more than 190, or if they have coronary artery disease and they are younger than 75, or they have angina or stroke and they're younger than 75, you kind of want to increase the statin, just risk factor modifications. Okay, another case that you may encounter, like is say 52-year-old woman came in with fatigue, okay, achy, and then you calcium, you check calcium 11.1. You check PTH is 85, and they tell you, okay, what's the diagnosis? This is obviously primary hyperparathyroidism, okay? Because calcium is 11. Usually if calcium 13, 14, this is malignancy. But if it's just 11, this is a primary hyperparathyroidism. So how do you, this is like, they want you to know how do you work up hypercalcemia? Because you just check the parathyroid hormone, okay? If it's elevated, primary hyperparathyroidism. If it's suppressed, then this is, you check PTHRP, vitamin D, and 125 vitamin D. If PTHRP elevated, malignancy. If 125 vitamin D elevated, this is granulomatous disease like sarcoidosis. If it's 25 vitamin D elevated, this is vitamin D toxicity. As easy as this. Now, another case that you may have, a 45-year-old man came in with difficulty with erectile dysfunction, okay, and then decreased early morning erections and sexual desire, okay. What's best next step in this patient of decreased early morning erection? Best next step, you do total testosterone, okay. Because this patient, you don't do a child penile tumescence test or anything like that, because morning erection is not there. So there is a clearly pathologic issue, like there's a clearly deficiency in testosterone in here, okay? And that brings us to the discussion of hypogonadism. So if somebody have hypogonadism symptoms like sexual dysfunction, loss of body hair, gynecomastia, hot flashes, loss of bone density, testicular atrophy, which is called the menopause of male, what do you do in this case? In this case, you check testosterone. Okay. So you see testosterone, even you confirmed on repeat testing, it's low. What do? You can even do free testosterone or sex hormone binding globulin. Okay. If they're also low, then you check the pituitary, okay? Just like the calcium, if it's high, you check parathyroid. You check the father of them. Which one is the father of calcium? It's the parathyroid. Father of thyroid is TSH. Who's the father of testosterone? Is LH, FSH. If it's elevated, this is a primary hypogonadism, like the defect in the testicle. Just do karyotype analysis. If it's low, this is secondary hypogonadism, the defect in the brain. So check prolactin, check iron studies, pituitary hormone, MRI of pituitary, like it's the brain is messed up here, okay? So that's the hypogonadism discussion. Okay, now you see 26-year-old woman came in with heat intolerance and tremor, and they ask you, okay, what's the best next step? You do beta blocker, okay? This is hyperthyroidism, and they tell you, look, how do you treat it? You treat it with beta blockers. And there are different types of thyroiditis. There is painless thyroiditis or just like Graves' disease. So you would ask me, what's the difference? So thyroid is high yield for the test and for real life as well. If there is painless thyroiditis, usually preformed thyroid hormone release, and usually happen 1 to 2 months, and usually no exophthalmos. And thyroglobulin level would be high and radioactive iodine uptake would be low. But in a Graves' disease, thyroglobulin level would be high, but the uptake is high too, okay? And then you could see goiter, ophthalmopathy, and excess thyroid hormone production as well. It's not like the thyroiditis is just like release of thyroid from, it's already there. But a Graves, there is extra production of thyroid hormone. So that's why it's not good, okay? Now, there is this patient, 64, have osteoporosis, and DEXA scan is like minus 2.6 at femoral neck, and they ask what's best next step. You do nothing, you check vitamin D. Yes, you check 25 hydroxy vitamin D. Okay. You really need to check vitamin D because this patient is clearly having osteoporosis, because there are many reasons for osteoporosis and you want to know why the patient having osteoporosis. So there could be endocrine reasons, could be metabolic, GI, renal, medications, and other reasons. So what are the endocrine causes? Like the hormones, like if the thyroid or parathyroid or cortisol goes up, or if the testosterone goes down. This is endocrine cause. Metabolic, if you have calcium or vitamin D deficiency or eating disorder. Okay. GI causes could be if you're not absorbing, like Crohn's disease, celiac, or liver disease. Kidney disease as well. Renal tubular acidosis can cause osteoporosis. Others, medications like carbamazepine, phenytoin for seizure, or if you have GERD, you're taking PPI. Everybody on PPI, but this can cause osteoporosis. You got to be careful. Glucocorticoid, it's a big one, you know. It's immunosuppression, just like cortisol high. Other causes, like if you have rheumatoid arthritis, multiple myeloma, alcohol use disorder, and immobilization as well. Okay. Now, here is a very common question that you could get asked, which is that they give you usually 52-year-old, they give you 52-year-old woman, okay? Let me change this font. Woman, okay, comes in with glucose. She was recently started on insulin, so you check glucose is 100. She tells you what is at home. It's 112. So you check A1C, and you see it's 8. Oh, this is not good. So A1C is high. So why is that? How do you know what's causing this issue? So in this case, the best next step, you do 2-hour post-meal glucose level. Okay, 2-hour post-meal glucose level. And this brings us to the insulin therapy. What do you do insulin? Like, what are the types of insulin? Okay. So just to make it easy, there are ones that need to be done twice daily. And there are one that long acting, and there are one short acting. Okay, and there's one intermediate. The long acting form, we have the Detamir, which is the Levemir, Glargine or Lantus, and Declodec. And we have the intermediate acting is the NPH insulin, which is the cheapest. Usually lasts 12 hours, so that's why you dose it twice daily. Okay. And we have the short acting, like regular insulin, slow onset and offset, and peak does not coincide with food peak, so it doesn't affect that. And usually lasts like 1 hour to 3 hours. And then we have Lispro, Aspart, and Glulazine, also 3 hours. NPH, usually duration of effect is 12 hours. Okay. The Levemir can last 6 to 24 hours. Okay. Levemir can be used one time daily or twice daily, usually most common twice daily. Glargine 1 time daily because it doesn't have peak. Levemir peaks at 8 hours. This one doesn't peak, just 24 hours. It's fine. Okay, peakless. And higher concentration of Glargine usually lasts for longer hours. And then you have Declodec, also same thing. Okay, and less likely to cause hypoglycemia. Declodec. But of course, the longer it is, the more expensive it is. Okay, now this is the insulin management. Now they give you a patient, 53 patients with large hand, man with large hands, headache, joint pain. This is obviously acromegaly. Okay. What is this patient's risk for? This patient is at risk for colonic neoplasia. Okay. This patient is at risk for colonic neoplasia. So what are the features of acromegaly? Makes everything big. So brain big, cause headache, visual field defect, cranial nerve defect. Musculoskeletal system could be big, frontal bossing, occlusion of the jaw, microagnathia, arthritis, carpal tunnel syndrome, enlargement of the hand and feet, skin thickening, hyperhidrosis, skin tag, hydrosis, skin tags. And then cardiovascular, cause big heart, cardiomyopathy, hypertension, heart failure, sleep apnea, okay. GI colonic polyps and cancer, diverticulosis can cause that. Endocrine can cause galactorrhea, hypogonadism, diabetes, hypertriglyceridemia. Other additional features cause enlarged tongue, enlarged thyroid, salivary gland, liver, spleen, kidney, prostate. All of those can grow bigger. Okay. So now you have someone that came in, 55-year-old, came in because of erectile dysfunction. And they usually give you a reason why is that. There is you check end-stage renal, maybe have end-stage renal disease. Okay, so you check testosterone. It's 520. Testosterone is good. So what would you do? This patient, you prescribe Viagra or sildenafil. Okay, would be helpful. Sildenafil would be a good option. Okay. That brings us to the discussion of very important topic: what causes erectile dysfunction? So there are a few things that can cause that. It could be vascular. There are vascular causes. There are neurogenic. There are psychogenic, endocrine, medication, and hypogonadism. Okay, so there are how much? 6 causes. So the vascular causes, it's known. We obviously know that smoking, hypertension, diabetes. Okay, usually you find bruit, decreased pulses. The neurologic, like also diabetic neuropathy, multiple sclerosis, and usually in a gradual onset, and you see loss of bulbo-cavernous reflex. That's what they tell you. Okay, and the psychogenic usually sudden, only with one partner, and then normal non-sexual nocturnal erection. So nocturnal erection is fine, but just like with the partner, and the erection is fine during masturbation as well. Psychogenic, and there is endocrine, like due to underlying disorder or abnormal TSH or prolactin, and there's medication. Okay, like it's usually related to when you start medication, and then you have erectile dysfunction, and could be some antihypertensive cause that, SSRI, anti-androgenic medications, and could be hypogonadism, usually gradual onset, just like the neurogenic, cause decreased libido, gynecomastia, testicular atrophy, and low serum testosterone. Okay. Now you see that another patient, 42-year-old woman, comes in with 7mm pituitary mass. Okay, and then you have milky discharge from the nipple. Okay, milky nipple discharge. So what risk for? Okay, they ask you what is the patient's risk for. This is osteoporosis. Okay, this patient's at risk for osteoporosis. So when do you treat someone have prolactinemia? Okay, if in females, if there's amenorrhea, galactorrhea, infertility, acne, hirsutism, then you need to treat it. Okay, we'll talk about the treatment. In males, if there's hypogonadism, erectile dysfunction, gynecomastia, which means basically if it's symptomatic. Both sexes, if there's osteoporosis or if there is enlargement of adenoma and mass effect symptoms like bitemporal hemianopsia, this is when you need to treat the prolactinoma. This is prolactinoma. Okay, to treat it, you treat with dopamine agonist like cabergoline. Okay, and if that doesn't work, then maybe consult surgery, see if they can do anything. Okay. All right. Now you have this patient, another patient who's 53, comes in because of progressive erectile dysfunction, loss of libido. Okay. Fatigue. So you check testosterone. It's 130. It's not testosterone. Just, oh, this is expected. You see FSH is 5. LH is 4. Okay. Prolactin is 10. What does that tell you? Okay, so and the patient is obese and the patient is diabetic. Okay, so testosterone is low, LH is low, FSH is low, obese, diabetic. What do you think? You think that is a pituitary pathology? This is hypogonadotropic hypogonadism. Okay, so what would you do? The best next step, you do MRI of pituitary, because this could be infiltrative disease that causing this destruction of the pituitary. So you want to know what's causing that. Okay, but mostly it could be diabetes. So what is the hypogonadotropic hypogonadism and diabetes? The risk factors: obesity and metabolic syndrome. How does it present? Like this patient: decreased libido, decreased energy and muscle mass, increased insulin resistance, low serum testosterone, low or inappropriately normal FSH/LH. FSH/LH should go up if the testosterone is low. If it's normal, that's also concerning. Indications for pituitary imaging. When do you do pituitary imaging? If the testosterone below 200 at age less than 65, or below 150 at age above 65, or if there is mass effect like headache, visual field defect, or if there is multiple pituitary hormonal deficiency like thyroid and growth hormone deficiency and there is high prolactin, that's when you need imaging. Okay, now this patient, they bring you a case. It's interesting case, like 76 with a refractory arrhythmia on amiodarone, came in with fatigue, lethargy. So you're a smart doctor, so you know there is a possibility that amiodarone messed up with the thyroid. So what do? You do labs. You see TSH is 12. TSH this is really high, right? You see free T4 is 0.7. This is very low. Okay, normal is 0.8 to 1.8. Okay, that's that low. It's very low. Okay, you check T3. T3 is low too. It's like 66. Normal is 80 to 200. So what would you do? Continue amiodarone and start levothyroxine. This one you can just fix the thyroid. You know, just supplement thyroid. Okay. That would be a good idea. If you supplement the thyroid gland, would be a good idea, you know, just supplement thyroid, to give them levothyroxine. Now that brings us to the discussion of amiodarone induced thyroid dysfunction. So how do you know if it's like in this case, just like the thyroid is low, TSH is high, just continue amiodarone, give them thyroid. Okay, now what if it's the opposite? Sometimes amiodarone causes hyperthyroidism. Then in this case, this is called amiodarone-induced thyrotoxicosis, not amiodarone-induced hypothyroidism. So if you have amiodarone-induced thyrotoxicosis, what do? You see based on the ultrasound, if there is, you do ultrasound. If there is high vascularity on the thyroid ultrasound, it's likely type 1. Okay, this may be amiodarone stimulated production of thyroid hormone. Okay, you treat it just like Graves' disease. Stop the amiodarone unless it's necessary. Give methimazole thyroidectomy in refractory cases. But if it was type 2, which is there's low vascularity on thyroid ultrasound, no goiter symptoms, and very low uptake on radio iodine scan, there isn't much uptake, you know. And then in this case, you can continue amiodarone unless it's not indicated, and you just treat with corticosteroid. Okay, because the second type is just like inflammatory version, but the first type is concerning. It's like Graves, you know. So you just treat it as is. Okay, now you have a patient came in with who's 53, came in, has medullary thyroid cancer. Okay, what's best next step? This one you want to check RET gene mutation. Why? Because there could be a risk of multiple endocrine neoplasia. Okay, and that brings us to the discussion of multiple endocrine neoplasia. So it's very easy to remember. If they have PPP, this is type 1. What does PPP mean? PPP means primary hyperparathyroidism, pancreatic tumor, and pituitary tumors. This is PPP. Okay. If there is medullary thyroid cancer, and Pheo, this is type 2. This is type 2. Type A, type 2A, affect the parathyroid hormone as well, called parathyroid hyperplasia. Type B causes marfanoid hepatitis. Marfanoid. Okay, mucosal and intestinal neuroma as well. Okay. B for marfanoid. Okay. So that's why you want to evaluate for metastatic disease, identify coexisting tumor, check RET gene mutation. Alright, so now you have another case. You see a patient came in, 56, came in because of cough, COPD. Okay, you do labs, you see calcium is elevated, 11. What would be your diagnosis? Okay, you check parathyroid hormone. Parathyroid hormone is 60. Okay, it's like in the upper high normal, and they tell you, okay, what's the diagnosis? This is primary hyperparathyroid. It's easy because the parathyroid is in the higher normal. You know, normal is 10 to 65, so it's a little bit higher. So you just, this is primary hyperparathyroidism. Okay. Okay, now you see this case is interesting. You see a 55-year-old woman who's diabetic, has type 2 diabetes, and has hypertension. So she's on hydrochlorothiazide, metformin, sitagliptin, amlodipine, calcium channel blocker, all the good stuff, statin, you know. And then they tell you what to do. How to start canagliflozin. Why? Because this patient is hypertensive, have heart failure, diabetic, they benefit from SGLT2 inhibitor. Okay, you hit two birds with one stone. You treat diabetes, treat blood pressure and heart issues, has mortality benefit. So it's very good. So what do you need to stop from these medications before you start it? So you need to stop DC, HCTZ, hydrochlorothiazide. Why? Because SGLT2 inhibitor has diuretic effects. Okay, so that's why you want to stop hydrochlorothiazide. What other effects of SGLT2 inhibitor? There's likely you're going to be tested with for that. It's a new drug and it's very important. Okay, so it's causes genitourinary infections, cause osmotic diuresis, metabolic disturbance, and orthopedic complications. So what are the GU infections? Cause candidiasis, UTI, and Fournier gangrene, but that's rare. Can cause osmotic diuresis, like causes volume depletion, symptomatic hypotension, and acute kidney injury. And cause metabolic disturbance like euglycemic diabetic ketoacidosis, and cause orthopedic complications like low trauma fracture, foot ulcer that may increase the amputation risk as well. Okay, that is the issue. Now another interesting, very high yield case. You see a 33-year-old woman came in with fatigue, weakness, anorexia, nausea, weight loss. Okay. Blood pressure low blood pressure, high heart rate. Okay, that's, you know, you start to get worried. You check potassium is 4.9. Okay, potassium is high. Check sodium is 131. Low sodium, high potassium. Okay, creatine is like 1.4. There's some dehydration. What's going on in here? What's the diagnosis? These are, whenever you see somebody weak, tired, high potassium, low sodium, this could be adrenal insufficiency. Okay, and what causes adrenal insufficiency? It can be caused by autoimmune or infectious diseases like HIV, fungal or TB, hemorrhagic infarction, and metastatic disease. How does it present? Present like in this case: fatigue, weakness, anorexia, weight loss. You have GI symptoms like nausea, postural hypotension, blood pressure drops because you don't have cortisol, you don't have aldosterone. It can also associate hyperpigmentation or vitiligo. Hyponatremia, hyperkalemia is typical and may lead to acute adrenal crisis, like abdominal pain, shock, fever, altered mental status. So how do you diagnose this patient? So if you see this patient, what would you do? You want to check ACTH, okay, and you want to check cortisol, and you want to do high dose ACTH stimulation test. Okay, it's very important because if those are low, if you see low cortisol, high ACTH, what does that mean? Because we said I will always call the father, test the father to see what's going on in here. The father of cortisol is the ACTH. So if this cortisol is low, the ACTH is high, the problem is with the son, it's primary adrenal insufficiency. But if the cortisol is low, the son is failure, but the father is failure as well. So it's caused with the father. It's called secondary, tertiary adrenal insufficiency. Okay. So if it's high ACTH, this is a primary. If it's low ACTH, this is secondary. The father is defective. That's why you have a defective son when you have a defective father. Okay. Now, this patient, they just ask you, how do you decrease the risk of cardiovascular disease? How to decrease cardiovascular risk? Okay. The answer is very expected as exercise. Exercise is always good answer. If you see it in the option, just think about it. Okay. Okay. Now, you have this patient, 55-year-old woman, came in with fatigue and developed panhypopituitarism after resection of large non-functional pituitary tumor. So developed panhypopituitarism. Okay. So she was put on hydrocortisone and levothyroxine, right? So you check regular lab because you need to follow up on them. You say TSH is 0.3, okay? This is very low TSH. So what could be, what do you need to do? Best next step. So how to further work up TSH? You do free T4 level, okay? You want to do free T4 level, that's what's going to give you if there is like central hypothyroidism or primary, because this one most likely central hypothyroidism. When does that happen? Usually mass lesion, like in this patient, pituitary adenoma, resection, pituitary surgery, trauma, radiation, infiltrative disease like sarcoidosis, hemochromatosis, Sheehan syndrome, empty cell syndrome as well. How does it present? Usually have mild hypothyroid symptoms and associated with other pituitary hormone deficiency. Can cause headache, visual field defect due to the mass as well. The way you diagnose it, both is going to be low T4, low TSH, or maybe normal TSH is fine too. And then you do MRI of pituitary. How do you treat it? Obviously, you do levothyroxine to keep free T4 in high normal range. And you do ACTH stimulation test before you do the ACTH stim test. And then you do levothyroxine. Okay. Why do you do ACTH stimulation test? Just to see if there's adrenal insufficiency with it. So you give cortisol with the levothyroxine. Okay, so now we talked about primary hypothyroidism. We talked about exercise. We talked about adrenal insufficiency. Talked about hydrochlorothiazide with SGLT2 inhibitor, primary hyperparathyroidism, marfanoid, like RET mutation, men syndrome. We talked about amiodarone and relation to the thyroid. We talked about MRI of pituitary, osteoporosis, sildenafil for low testosterone, for normal testosterone and erectile dysfunction, colonic neoplasia for acromegaly. 2-hour post-meal glucose monitoring is a good option to see why the patient A1C high. 25-hydroxyvitamin D is good if there's osteoporosis. Beta blocker for hyperparathyroidism. For hyperthyroidism, I mean. Total testosterone if there is decreased morning erection. Increased statin if there is a high risk ASCVD. Breast malignancy increase in Klinefelter syndrome. Workup for hypertension, this is the ones. And then you want to stop the gluperide in elderly patient who has CKD, okay? That summarizes our discussion of the endocrine section, first section of endocrine. Thank you for